Hello everyone, I am myself Dr. 𝗏𝐼𝐸𝐵𝐽𝐻𝐫𝐢𝐻𝐫. I am the general medicine educator. So in this particular section, I'll be doing the quick revision of the acid-base interpretations. So in the acid-base interpretations, the very important equation that you need to remember throughout is the H plus ion is equal to 24 multiplied by partial pressure of the carbon dioxide divided by bicarbonate. That means the levels of the H plus ion concentration in our body, it completely depends on the carbon dioxide levels and as well as the bicarbonate levels, right? So if at all, if the H plus ion has to remain constant, please remember the PCO2 and the HCO3, they should change in equal direction and in equal proportion. Then the H plus ion will remain constant. And the next very important is the pH and as well as the H plus ion concentration, they are always inversely proportional to one another. That is, pH is directly proportional to 1 by H plus ion concentration. So in the sense, when the pH increases, what will happen to the H plus ion concentration? Decreases. In other way around, if the pH decreases, there will be increase in the H plus ion concentration, right? So it is inversely proportional to one another, and that can be seen in the graph as well. So at the levels of the higher H plus ion concentration, the pH is on the lower side, whereas on the lower H plus ion concentration, the pH is on the larger side, or in the sense the pH is increased. So that is the relation between the pH and as well as the H plus ion concentration. Now, what are the normal values? So if you take the normal values of the pH, it is 7.36 to 7.44, and some of the books mention it as 7.35 to 7.45 also, right? But in the standard textbook of the ICU, that is Paul Merino, the values that is given is 7.36 to 7.44. And what will be the partial pressure of the carbon dioxide? You take this 36 of 7.36 and 44 of 7.44. So 36 to 44, that is a normal partial pressure of the carbon dioxide. And if you take the bicarbonate value, the levels of the bicarbonate will be 22 to 26 milliequivalents per liter. That will be the normal levels of the bicarbonate. Now, the value of your carbon dioxide depends upon the lungs or the respiratory system. The value of the bicarbonate, it completely depends upon the renal status, that is metabolic status. So primary increase in carbon dioxide in the body, it is seen in case of the respiratory acidosis. Now why is that? Because once the carbon dioxide levels are increased, the levels of the carbon dioxide in our body is maintained by the lungs. Once the levels of the carbon dioxide is increased, the carbon dioxide will combine with water molecule to form the carbonic acid, which is an acid. So more is your carbon dioxide levels, more will be the levels of the carbonic acid, and that will result in the acidosis. And what acidosis? Respiratory acidosis. In other way around, if the levels of the carbon dioxide is decreased, that will result in the respiratory alkalosis, right? That will result in the respiratory alkalosis. Okay. And you take the bicarbonate, the levels of the bicarbonate are decided by the renal status, and any change in the bicarbonate, we call it as metabolic. So bicarbonate, it is an alkaline substance. So because it being an alkaline substance, if the level of the bicarbonate is increased, that we call it as metabolic alkalosis, right? That we call it as metabolic alkalosis. And if the levels of the bicarbonate are reduced, then we call this as the metabolic acidosis, right? We call this as the metabolic acidosis. So this is about the change in carbon dioxide and as well as the bicarbonate. So if change in carbon dioxide is there, that is respiratory. If there is change in bicarbonate, that is metabolic, right? Now based on this, you need to know which is the primary disorder, which is the secondary disorder. Because what is that we have discussed? H plus ion concentration is equal to PCO2 by the bicarbonate. So if bicarbonate changes, carbon dioxide also should change. Or if the carbon dioxide decreases, even bicarbonate also should decrease. Then only the H plus ion will remain constant, right? So whatever the changes first, that is called the primary disorder or the primary change, and whatever the change that occur in compensation to the primary, that is called the compensatory change. Like for example, the primary disorder, it is respiratory acidosis. So in case of the respiratory acidosis, there will be increase in carbon dioxide. Once there is increase in carbon dioxide, what should happen to bicarbonate in order to see that the H plus ion remain constant? Even bicarbonate also should increase. Now, when bicarbonate increases, what is the compensatory change? It is compensatory metabolic alkalosis. Right? Compensatory metabolic alkalosis. Whereas you take respiratory alkalosis, where there will be decrease in carbon dioxide. So once there is decrease in carbon dioxide as a primary disorder, what will be the compensatory change? There should also be decrease in bicarbonate as well. Once there is decrease in bicarbonate, that we call it as, so the compensatory will be metabolic acidosis. Right? The compensatory will be metabolic acidosis, right? And if the primary disorder is metabolic acidosis, what should happen to your bicarbonate? There will be decrease in bicarbonate. Once there is decrease in bicarbonate, there will also be decrease in carbon dioxide levels as well. Once there is decrease in carbon dioxide, so the compensatory event will be respiratory alkalosis. And if there is metabolic alkalosis as the primary disorder, what should happen to your bicarbonate? There should be increase in bicarbonate in case of metabolic alkalosis. So once there is metabolic alkalosis, once there is increase in bicarbonate, what should happen to carbon dioxide? Even the carbon dioxide also should increase. And once there is increase in carbon dioxide, that we call it as respiratory acidosis. Right? We call that as the respiratory acidosis. Okay. So this is the primary and as well as compensatory. Whatever occurs compensating to the primary, that is called as the compensatory change, right? Now, after having discussed about the primary and as well as the compensatory disorders, let me just give you a brief idea of what are the etiologies that will be causing respiratory acidosis. So respiratory acidosis means there should be increase in the carbon dioxide. So central causes. What are the central causes? Like cerebrovascular accident where there is injury to the brainstem, because it is in the medulla oblongata and as well as in the pons, you have the presence of the respiratory centers. So in the medulla oblongata, you have dorsal respiratory group and ventral respiratory group, whereas in the pons, you have pneumataxic center and as well as the apneustic center, right? So if there is central pathology, that is in case of the cerebrovascular accidents, there will be suppression or there will be decrease in the respiratory rate. Once there is decrease in respiratory rate, what will happen to the carbon dioxide levels? There will be increase in the carbon dioxide levels. Then followed by that, the drugs like morphine, sedatives and as well as the anesthetics. So this morphine, sedatives and as well as anesthetics, they suppress the respiratory center. Once they suppress the respiratory center, what will happen to the carbon dioxide levels? Increases. Next is the CNS infection. All these are the central causes for increase in the carbon dioxide levels, right? And that will result in the development of respiratory acidosis. And we have few more conditions which will be causing respiratory acidosis, that is the pathology at the level of cervical spine or the pathology at the level of respiratory muscles. So if there is high cervical spine injury, like which is giving a root value to the phrenic nerve which will supply the diaphragm. So if there is high cervical spine injury, there will be like root value for the phrenic nerve is damaged and nerve supply to the diaphragm is gone, and that will result in respiratory muscle paralysis. That will cause respiratory failure, that will cause increase in carbon dioxide levels, and that will be type 2 respiratory failure, where there will be increase in carbon dioxide causing respiratory acidosis. And the other etiologies will be neuromuscular junction disorders or the muscle disorders. Neuromuscular junction disorders like myasthenia gravis, or the muscular disorders. What will be the muscular disorders? Like Duchenne's muscular dystrophy, right? Then myotonic dystrophies, right? Or in case of Guillain-Barré syndrome, motor neuron disease. So there will be muscle paralysis. Once there is muscle paralysis, the individual will have increase in carbon dioxide resulting in respiratory acidosis, right? Next, coming to the respiratory alkalosis. So if you take the respiratory alkalosis, there should be decrease in carbon dioxide, right? There should be decrease in carbon dioxide. So there will be increase in respiratory rate and causes carbon dioxide washout. That is observed in patients with the congestive heart failure, in high altitude pulmonary edema, pulmonary embolism, and flail chest. So in all these scenarios, there will be increase in respiratory rate, and this increase in respiratory rate will cause decrease in carbon dioxide by causing carbon dioxide washout. So this will result in the metabolic alkalosis. So if you see this question now, respiratory alkalosis, it is characterized by, so in respiratory alkalosis, what should be the carbon dioxide? There should be decrease in carbon dioxide, and once there is decrease in carbon dioxide, that is called respiratory alkalosis. What should happen to the pH? There should be increase in the pH. So among the options given to you, that is raised partial pressure of carbon dioxide and elevated pH, decreased plasma bicarbonate and decreased PCO2, decreased PCO2 and increased pH, and decreased pH and decreased PCO2. So what will be the correct answer? Decreased PCO2 and as well as the increased pH. So that will be the respiratory alkalosis, right? Then followed by that, you see the next question. In a patient, partial pressure of the oxygen is 85 millimeters of mercury and PCO2 is 50. And how much is the pH of the individual? pH of the individual is 7.2, which is acidic pH, right? And what happened to the carbon dioxide? Carbon dioxide is around 50 millimeters of mercury. In the sense, the carbon dioxide is increased. Then followed by that, you take the bicarbonate. So bicarbonate, it is around 20 milliequivalents per liter. That means it is decreased. So both of them, carbon dioxide and bicarbonate, did not change in same direction. Both of them, they have changed in opposite direction. Now, what is this patient suffering from? Respiratory acidosis with compensated metabolic alkalosis, primary respiratory acidosis with decompensated metabolic acidosis, primary metabolic acidosis with respiratory acidosis, and metabolic alkalosis. Now in these type of questions, you should be able to decide which is the primary disorder, right? In these type of questions, you should be able to decide which is the primary disorder. So now how will you decide the primary disorder? The primary disorder is decided by the direction change of the pH and as well as PCO2, right? The direction change of pH and PCO2 will decide what is the primary acid-base disorder. Now if suppose, if the pH and carbon dioxide, if they are changing in opposite direction, like in this scenario, if you see pH is decreasing, carbon dioxide is increasing. When both of them are changing in opposite direction, what is the primary acid-base disorder? The primary acid-base disorder will be respiratory, right? The primary acid-base disorder will be respiratory. And respiratory what? Because the pH is reduced, it will be respiratory acidosis. So the rule is, if pH and PCO2 changes in opposite direction, the primary acid-base disorder is respiratory. Whereas if pH and PCO2, if they change in same direction, that means either both of them decreased or both of them increased, then the primary acid-base disorder will be metabolic. Please remember, this is a very, very important point, right? Now, based on this, what is the correct option here? So the pH is reducing and carbon dioxide is increasing. So it is a primary respiratory acidosis. And in response to your carbon dioxide, is your bicarbonate changing in the same direction? No, it is not changing in same direction. That means it is decompensated. Right? Decompensated what? Bicarbonate is reduced. When bicarbonate is reduced, we call this as metabolic acidosis. So the correct answer here is the primary respiratory acidosis with decompensated metabolic acidosis is the correct answer. So from this question, what is that you need to learn? You need to learn how to decide the primary acid-base disorders, right? We'll try to do a few more questions of making out the primary acid-base disorders. So a patient with salicylic acid poisoning has the following ABG analysis, where the pH is 7.12, PCO2 is 18 and bicarbonate is 12 millimoles per liter. the resulting acid base abnormality can be labeled as. So if you take the pH, what has happened to pH? 7.12, which is reduced. And if you take the carbon dioxide, that is 18, that is also reduced. And if you take the bicarbonate, that is 12 millimoles per liter, that is also reduced. So your pH and PCO2, both of them have changed in same direction. When pH and PCO2 changes in same direction, what is the primary acid base disorder that we have discussed? The primary acid base disorder will be metabolic. Metabolic what? Metabolic because the pH is reduced, that is metabolic acidosis. Right? Now, what is the compensation? Because your carbon dioxide and your bicarbonate are changing in same direction, so there is a sort of compensation. So primary metabolic acidosis with compensatory respiratory alkalosis because the carbon dioxide is reduced. So the answer is A, that is metabolic acidosis with the respiratory alkalosis. Okay, so the answer is A. Now we'll try to solve one more question on the deciding the primary acid base disorder. If blood gas analysis reveal the pH of 7.52, which means an alkalotic pH, and carbon dioxide given is 30, which means that the carbon dioxide is reduced. Now this will be right. This will be compensated by is the question. So now you see here, the pH and PCO2 they are changing in opposite direction. When they are changing in opposite direction, what is the primary acid base disorder? That is primary respiratory. Right? The primary acid base disorder is respiratory. Okay. So when the primary acid base disorder is respiratory, the pH is increasing. What do we call this as? Respiratory alkalosis. And if there is respiratory alkalosis, what should be the compensation? The compensation should be metabolic acidosis. Right, the compensation should be metabolic acidosis. So here, what should happen to your bicarbonate value? Bicarbonate value should also be decreased. When bicarbonate value is decreased, what do we call this as? Metabolic acidosis. So what is the question asked? This will be compensated by. So this will be compensated by the compensatory metabolic acidosis. So the answer is C here, third option. Now, you take the next question. Arterial blood gas analysis of the patient reveal the pH of 7.2 and bicarbonate is 36 and PCO2 is 60. Right, PCO2 is 60 millimeters of mercury. And if you take the bicarbonate is 36 millimoles per liter. Now, what is the abnormality in this patient? Alright, now you see here, what has happened to pH? Reduced. And what has happened to carbon dioxide? Increased. Both of them have changed in opposite direction. When both of them changes in opposite direction, what is the primary problem? That will be respiratory. Respiratory what? Because the pH is reduced, we call this as respiratory acidosis. Right? We call this as the respiratory acidosis. So respiratory acidosis with what has happened to bicarbonate? Bicarbonate is also increased. That is in the direction of the carbon dioxide. So with metabolic alkalosis. So the answer here is the primary respiratory acidosis with metabolic alkalosis. So the correct answer is A. Right? So this is how you need to decide the primary acid base disorders. Right? So if both pH and PCO2 changes in opposite direction, the primary acid base disorder is the respiratory. And if pH and PCO2 change in opposite direction, the primary acid base disorder is respiratory. And if pH and PCO2 changes in same direction, then the primary acid base disorder will be metabolic. Right? Now, after having discussed about like how to decide the primary, now let us discuss about the anion gap. Now, what exactly is the anion gap? See, anion gap, it is the measure of the unmeasured anions. Right? Measure of the unmeasured anions. That is what is called as the anion gap. So, anion gap, it is a measure of, right? It is a measure of the unmeasured anions. Now, in our body, the cations will be equivalent to that of the anions, but there are some unmeasured cations and there will also be unmeasured anions. Now, if you take the difference between these now, you get the anion gap. So, anion gap is equal to sodium minus chloride plus bicarbonate. That is what is your anion gap, right? And one of the very important, the anion is the albumin. Now, in conditions wherever there is low albumin level, you have decreased anion gap. And what are the examples of that? That is in nephrotic syndrome. So in case of nephrotic syndrome, you have decreased anion gap, right? In nephrotic syndrome, you have decreased anion gap, right? Now, the another point what I wanted to tell you here is about the normal anion gap. How much is the normal anion gap? Normal anion gap is around 8 to 12 milliequivalents per liter. Right? 8 to 12 milliequivalents per liter. It is a normal anion gap. Now, if the anion gap, if it is increased more than 12 milliequivalents per liter, then we consider it as the high anion gap metabolic acidosis. Okay. Now, if the anion gap is decreased to less than 8 milliequivalents per liter, that is low anion gap. And if the anion gap, if it is 8 to 12, we consider it as normal anion gap. And we calculate anion gap in the scenario of metabolic acidosis. Right? We calculate the anion gap in the scenario of the metabolic acidosis. Right? Now, you should know, okay, you see the question, all of the following causes high anion gap metabolic acidosis except. So, what are the causes for the 𝐒𝐲𝐫? So, please remember the mnemonic as the 𝗠𝐞𝐝. These are the causes for the high anion gap metabolic acidosis, out of which K stands for diabetic ketoacidosis or ketoacidosis. Then U stands for uremia, that is in renal failure, right? That to end stage renal failure, I mean to say. The word L stands for lactic acidosis. Right? The word L will be lactic acidosis and the word T will be toxins. Okay, so this is the mnemonic for the high anion gap metabolic acidosis, that is 𝗠𝐞𝐝. Ketoacidosis, uremia, lactic acidosis, and as well as the toxins, right? Now, so all of the following cause the high anion gap metabolic acidosis except the answer here is the 𝗂𝐴𝐴𝐴. Lactic acidosis, it will cause. Salicylate poisoning, it will cause. Ethylene glycol poisoning, even that is a toxin, that will cause the high anion gap metabolic acidosis. But 𝗂𝐴𝐴𝐴, you will have normal anion gap metabolic acidosis. Right? 𝗂𝐴𝐴𝐴, you will have normal anion gap metabolic acidosis. Okay. So, yeah. Now, apart from this 𝗠𝐞𝐝, you can just see what are all the various toxins. Okay. So, yeah, this is like the enlarged mnemonic, right, of the 𝐒𝐲𝐫. That is cat mud piles. Actually, you have 𝗠𝐞𝐝 only. The T is toxins. So, you have the various toxins which are causing high anion gap metabolic acidosis, like salicylates, ethanol, ethylene glycol, iron, isoniazid, then paracetamol, fenformin, paraldehyde, the alcohol, methanol. So these are all the toxins, and even carbon monoxide, cyanide, aminoglycosides, theophylline, toluene. These are all the toxins that will be causing the high anion gap metabolic acidosis, right? So this is about the conditions that will be causing 𝐒𝐲𝐫. Next is you take 𝐛𝐬𝐽, that is normal anion gap metabolic acidosis. So if you take the normal anion gap metabolic acidosis where the anion gap is maintained, so the mnemonic is the used car. So what is this used car? The word U stands for ureteral diversion, S stands for saline infusion, exogenous acid, diarrhea, carbonic anhydrase inhibitors, adrenal insufficiency, and then renal tubular acidosis. These are all the conditions where you will have normal anion gap metabolic acidosis. So you see this uretral diversions. Okay, that is 𝗂𝐵𝐼𝐻𝐼𝐻-ostomy, uretral diversion. You have the presence of the normal anion gap metabolic acidosis, right? Now, let us try to solve some questions on the topic of the anion gap. Now, you see this question. We have a 10-year-old boy with short stature presented with polyuria and as well as the polydipsia. Laboratory values, the pH, it is 7.34. That means there is acidosis. And the carbon dioxide given is 32, which means it is reduced. pH is also reduced. And the bicarbonate value, it is 16, which means it is also reduced. So both pH and PCO2, both of them have been reduced. When pH and PCO2, both of them are reduced, what do we consider this as? This we consider it as, what is the primary disorder? The primary disorder is metabolic. Right, the primary disorder is metabolic. Metabolic what? The pH is reduced. So we call it as primary metabolic acidosis. Primary metabolic acidosis. Alright. Now, the point here is, what has happened to carbon dioxide? Reduced. So we call it as with respiratory alkalosis. So we are able to make out what is the primary acid-base disorder. But the question asked is metabolic alkalosis, non-anion gap metabolic acidosis, anion gap metabolic acidosis, and respiratory acidosis. So your A and D is ruled out. Now you should be able to make out whether it is B or C, because in both of these scenarios it is metabolic acidosis, but you need to calculate the anion gap. Now what is the formula for the anion gap we have discussed? That is sodium minus chloride plus bicarbonate. So we will try to incorporate the values now. How much is the sodium value? The sodium value is 140, right? Minus how much is the chloride value? That is 114, plus how much is the bicarbonate value? That is 16. So if you calculate this, the anion gap that you will get is 10. Right? If you calculate this, the anion gap what you get is 10. So 10 is considered as the normal anion gap. So it is considered as non-anion gap metabolic acidosis. And always remember, we don't take potassium into consideration. Right? We don't take potassium into consideration in the calculation of the anion gap. Right? So even though potassium is given, please don't take potassium into the value of calculation of the anion gap. Right? Now, we'll try to solve about the questions on related to the compensation. So we have 54-year-old widower with history of chronic obstructive pulmonary disease and was rushed to the emergency department with increasing shortness of breath, pyrexia and productive cough with yellow-green sputum. He has difficulty communicating because of his inability to complete a sentence. One of his son, Jacob, says that he has been unwell for past 3 days. Upon examination, crackles and wheeze can be heard in the lower lobes. He has tachycardia and a bounding pulse. Measurement of the arterial blood gas shows the pH of 7.3, PCO2 of 68 millimeters of mercury, and bicarbonate is 28 millimoles per liter, and PaO2 is 60 millimeters of mercury. How would you interpret this? Right? How would you interpret this? Now, so you see here, what has happened to the pH? 7.30, which means it is reduced. And what has happened to carbon dioxide? It is 68, which means it is increased. And what has happened to bicarbonate? Bicarbonate is 28, right? That is also increased. So your carbon dioxide and bicarbonate has changed in same direction, but your pH and PCO2, they are changed in opposite direction. So what is the primary acid-base disorder? So primary acid-base disorder will be respiratory. Respiratory what? Respiratory acidosis. Right? The primary acid-base disorder will be respiratory acidosis, where the pH is 7.30. Now, the point is, whenever there is respiratory acidosis, what will be the compensation? The compensation will be metabolic alkalosis. right? But what is given to us? Respiratory acidosis uncompensated, respiratory acidosis partially compensated, metabolic alkalosis uncompensated, metabolic acidosis partially compensated, right? So here the correct answer is respiratory acidosis, which is partially compensated. Why? Why am I using this word partially compensated, right? So I will take the same clinical scenario and I will try to give you in 3 different ways, and when to tell partially compensated, when to tell uncompensated, right, and when to tell fully compensated. We'll try to discuss that. So now in that question, what was there? Respiratory acidosis was there, and because of which the pH was how much? 7.30, right? Now whenever there is respiratory acidosis, right, what should happen to the bicarbonate? Whenever there is respiratory acidosis, what should happen to the bicarbonate? If suppose bicarbonate also, in respiratory acidosis carbon dioxide increases, right? And what should happen to bicarbonate? Even bicarbonate also should increase. If suppose, if bicarbonate did not change at all, then we call it as the uncompensated, right? Then we call it as the uncompensated, right? Now if suppose your carbon dioxide is increased, and because of which bicarbonate is also increased, and because the bicarbonate is increased, the pH is normalized, this we call it as fully compensated, right? This we call it as fully compensated, right? Whereas you take the third one, your carbon dioxide is increased, but if you take the bicarbonate also increased, but right, but the pH is still abnormal, right? But the pH is abnormal, right? So even though bicarbonate is increased but the pH is abnormal, this we call it as partially compensated, right? This we call it as partially compensated. So this is very well, and you can apply the same rule for all respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. For all of them the same rule applies, right? That means this is like your primary disorder. Now in response to primary, if the compensatory event is not at all changing, we use the word uncompensated. And in response to primary, if the bicarbonate is increased and the pH is normalized, that we call it as the fully compensated. Whereas in response to primary, the bicarbonate is increasing but the pH is abnormal, that we call it as the partially compensated, right? So this is about when to call it as the uncompensated, fully compensated, and as well as partially compensated, right? Next. Now we'll try to make out this question. So in this question, what is that you are observing? That is, your bicarbonate is increasing in the direction of your primary, that is your carbon dioxide, but the pH did not normalize. That is the reason why we call this as partially compensated. That is the reason why we call this as partially compensated, right? Next. Now you see the next question. So Carl, an elementary student, was rushed to the hospital due to vomiting and decreased level of consciousness. The patient displays slow and deep breathing, and he is lethargic and irritable in response to the stimulus. He appears to be dehydrated, his eyes are sunken and mucous membrane are dry, and he has a 2-week history of the polydipsia, polyuria, and weight loss. Measurement of the ABG shows the pH 7.0. Then if you take the carbon dioxide, that is 23. So pH is reduced. And what has happened to carbon dioxide? Even the carbon dioxide is also reduced. And you take the bicarbonate. Bicarbonate is 12 millimoles per liter. So the pH is reduced, and carbon dioxide is also reduced. Both of them have changed in same direction. When both of them have changed in same direction, the primary acid base disorder is metabolic. Metabolic what? Because the pH is reduced, we call it as the metabolic acidosis. Now, when carbon dioxide, the primary is bicarbonate. When bicarbonate has reduced, is your compensatory carbon dioxide changed? Yes, it has changed. But is the pH normalized? No, the pH is not normalized. So what do we call this as? Metabolic acidosis, partially compensated. Why it is partially compensated? Why? Because the carbon dioxide reduced, but the pH did not normalize. So that we call it as the metabolic acidosis, partially compensated, right? So the correct answer is fourth option. Then you see the next question. A cigarette vendor was brought to the emergency department of a hospital after she fell into a ground and hurt her left leg. She is noted to be tachycardic and tachypneic. Painkillers were carried out to lessen her pain. Suddenly, she started complaining that she is still in pain and now experiencing muscle cramps, tingling, and paresthesia. Measurement of the ABG revealed the pH is 7.6, right, which is increased. And if you take the carbon dioxide, that is 31 millimeters of mercury, which means it is decreased. Then you take the bicarbonate. Bicarbonate is 25, which means it is normal. Okay. Now, what is the primary acid base disorder here? So pH is increased and PCO2 is decreased. So the primary acid base disorder will be respiratory, because both of them have changed in opposite direction. And respiratory, what? The pH is increased, so we consider it as the primary respiratory alkalosis, right? Now, in case of the primary respiratory alkalosis, your carbon dioxide is decreased, but is your bicarbonate changed? Bicarbonate did not change at all. Bicarbonate is within the normal limit. So that we call it as the respiratory alkalosis, which is uncompensated. Now, why is that I'm using the word uncompensated? We are using the word uncompensated because your bicarbonate did not change at all. Bicarbonate did not change at all. That is the reason why we use the term called uncompensated, right? Next. Then followed by that, Ricky's grandmother has been suffering from the persistent vomiting for past 2 days now. She appears to be lethargic and weak and has myalgia. She is noted to have dry mucous membrane and her capillary refill, it takes more than 4 seconds. She is diagnosed as having gastroenteritis and dehydration. Measurement of the ABG shows where the pH of the individual is 7.5, and then partial pressure of the carbon dioxide, that is around 40 millimeters of mercury, and the bicarbonate value, that is around 34 millimoles per liter. So what has happened to pH? The pH is increased. And what has happened to carbon dioxide? The carbon dioxide is within the normal limit. And what has happened to bicarbonate? Bicarbonate is increased. Okay. Now, the point here is the pH. The pH is the alkalotic pH, right? But carbon dioxide did not change. What is the only change? Bicarbonate. So it is metabolic alkalosis, right? Metabolic alkalosis. So you take the metabolic alkalosis, we have two options. Metabolic alkalosis uncompensated, metabolic alkalosis partially compensated. Now, when the bicarbonate change, the carbon dioxide also should change. But here what has happened? Your carbon dioxide did not change at all. So that we call it as the metabolic alkalosis uncompensated, right? Metabolic alkalosis uncompensated. So the answer here is C here.